And I'd like to welcome you and say thank you for joining us today. I am Trish Hutcherson, Orion's Marketing Director, and I will be with you throughout today's session as your moderator. And on behalf of everyone at Orion and CSI, we hope you enjoy today's presentations. Before we get started, I do want to just run through a few housekeeping items. We are going to mute the phone lines today, and if at any time you do have a question, please enter them into the GoToMeeting dashboard on your screen. Technical and or logistical questions will be answered in real time. However, questions related to the content of the presentation will be answered at the conclusion of the presentation. Though, please feel free to type in your questions at any time, and we will run through all of them at the completion of the presentation. We will be sending you a short survey after today's session. If you could just complete that, it's a quick 5-question survey just to let us know how we did and provide your feedback. We would certainly appreciate that. And with that, I'd like to introduce today's speaker, Jenny Studdard. Jenny is a senior consultant for coding strategies with over 15 years of experience in medical billing, coding, and compliance. She has served as Chief Compliance Officer for Diagnostic Health Corporation, where she was integral in the development of SOX policies and procedures, as well as the implementation of both SOX and regulatory compliance programs. Today, Jenny provides support and services for CSI clients, which includes performing on and off-site audits, operational reviews, charge master reviews, education and training, as well as providing coding support. Jenny holds a bachelor's degree in humanities from the University of Alabama, and she continues to present regionally and nationally to groups such as the Healthcare Compliance Association, Children's Hospital Association, Wisconsin Medical Society, and regional RBMA chapters. And so with that, welcome, Jenny, and whenever you are ready, please feel free to go ahead and get started.
Okay, great. Thanks, Trish. I think we should just jump right in. There are a lot of changes this year in radiology for us to talk about. So as we look at this year's radiology updates, we will look at reimbursement. We'll talk about reimbursement updates. We're going to look at some of the coding updates in the diagnostic and the interventional areas. And then we'll wrap up by talking about some of the importance of the PQRS measures. We don't go into detail on those, but just kind of stressing the importance of getting started in that area. So let's jump in with our reimbursement update, because we all know that that is why we do what we do, is to make sure that our reimbursement is appropriate to the services that we're doing. Some really important things to keep in mind. At the hospital level, every year they update the reimbursement for specific codes, and they analyze the charge information from the prior year to determine what the cost of providing those procedures was. So when we think about new codes coming out, it's kind of a hit or miss thing for them to define reimbursement for those new codes. Sometimes it works out well, sometimes it doesn't, especially when they are combining CPT codes. A good example is what happened with the CT abdomen and pelvis combined codes. When they were initially published in 2001, they came out at less than what an abdominal study alone was reimbursed, which was very shocking to the entire radiology community. And based on feedback and then the claims information, the claims data, they upped the reimbursement for that code in 2012, and now they're going back down in 2013. And some of this is, their study of what it costs, the cost associated with doing the procedures. They're trying to level the playing field some with the reimbursement across multiple procedures, and they believe that there's some cost savings to performing multiple procedures in a single session. So you'll see that they change these procedures up and down. This year for the hospital, they're going to have on the single code about a $100 decrease. On the multiple imaging composite codes, it's $30 to $40. So that's an important thing to know from the hospital side. When we look at packaging, hospitals have terms packaging and bundling. In the physician side, we only worry about bundling. Packaging from the hospital perspective is a reimbursement term alone. It has nothing to do with coding. So in their fee schedule, there are certain things that will be paid and certain things that they consider the payment has been packaged with the payment for the primary procedure. So image guidance is a good example. Image guidance is packaged into the surgical procedure. But if we don't report image guidance, it looks like the cost for doing that procedure is less than it truly is. So even when things are packaged, we still report those CPT codes on our claim forms in the hospital setting. The only exception to that is if it's not only packaged, but it's also bundled according to CCI edit. So from the hospital perspective, we really have to separate our packaging from bundling. And bundling is a coding definition. It's, you know, when one CPT code is actually a component or a part of another CPT code, so we wouldn't split that out and bill that separately. Packaging is just reimbursement. It's where they've decided that they will pay everything that's associated with this surgical service or this procedure under this one code, even though multiple codes might make up the total service. So that's packaging. And again, it's really important that hospitals continue to report on their claim forms services that are packaged, because if they're not reported, their cost of providing that service looks like it's much less than it really is. And then that next year, CMS could lower their reimbursement for that surgical service or for that main procedure. When we talk about physician reimbursement, there's some changes this year. We have the additional reduction for the professional component for multiple services on the same day for physicians in the same group. So in 2012, they held off on that. They said they weren't going to implement the multiple procedure payment reduction for physicians within the same group because they needed to work out some technical claims processing issues. In 2013, they've implemented this. So if physicians within a group practice read multiple studies, say one reads the CT of the chest, one reads the CT of the abdomen, they're going to consider that multiple exams on the same day, and they're going to reduce the professional component of the second study for that patient, even though it's a different physician. The other important reimbursement news is that the conversion rate was frozen for 2013. So instead of being reduced like it was originally projected to be in the final rule, legislation was passed that froze the conversion rate and extended or implemented a zero decrease, and that's to the end of the year. Some years they bumped it off 3 months, and then 9 months. They went ahead and extended it to the end of the year in hopes that they'll come up with a long-term solution by the end of 2013. So that's the plan, is that they come up with a long-term solution. But in the meantime, we have our same conversion path at the end of this year. There's some updates to the CCI manual, and in radiology, one specific one was very shocking, and we had no heads up. Nobody knew that this was on anybody's radar to change, the coding guidance or the bundling guidance. So in the 2013 CCI policy manual, it says if a breast biopsy, needle lock wire, metal localization clip, or other breast procedure is performed with radiologic guidance, and then they include all of them: ultrasound, CT, MR, stereotactic, and mammographic. So any radiologic guidance. The physician should not separately report a post-procedure mammogram code, and then they list all the mammogram codes for the same patient encounter. Their intention is that radiologic guidance includes all imaging required to perform the procedure, and they believe that the clip placement or confirmation of the appropriate location of the clip is a component of the procedure, that is something that's required to complete the procedure. There has been discussion on several of the listservs about that this doesn't apply to facilities because it says physician. The CCI manual in the introduction of Chapter 1 says that they utilize the term physician to mean practitioners, hospitals, providers, or suppliers that are eligible to bill the HCPCS or CPT code that is being discussed in that policy. So it's not just a physician. It is anybody that's billing the HCPCS code for, needle wire localization, breast clip placement, any of those things. Any provider that would bill it, whether it's hospital, physician, facility, freestanding facility, cannot bill that post-procedure mammogram for Medicare patients. That is the new rule as of January 2013. And again, that was something that we were very unprepared for. They kind of added that to the National Correct Coding Policy Manual without really any heads up or any full warning that they were even thinking about changing that guideline. So now let's go into our coding updates, and we'll talk about our diagnostic updates first. There's not as many diagnostic or not as many, earth-moving updates in our diagnostic section. They deleted the bronchography code. I don't think that's a big deal because we didn't really do that very much anymore, if at all. So those codes are now deleted. The cervical spine x-ray codes they've updated, and this is in an effort to make them more compatible with the protocols that we currently use in current medical treatment regimens and protocols. So they're going from 2 to 3 views to 3 views or less. Minimum 4 views is 4 or 5 views. And then the code that was always a struggle, complete with oblique, flexion, and or extension, is now just 6 or more views. So for our physicians, when they're dictating, it's important for them to let us know how many views. We don't have to concentrate as much with our complete code on knowing if oblique and flexion or extension views were included, because that's no longer required by code definition. Now we just need to know the number of views. There's an interesting little tidbit to this, because you'll notice 72040 says 3 views or less. And then we still have our single view spine code. So we don't have any interpretation from the AMA or the ACR on whether we should use the 72040 for a single view C-spine or whether we should continue to use a single view any spine. So we're looking for clarification from them on how those 2 codes will interact, since the update to the C-spine code does now say 3 views or less. That will be something we'll look forward to coming out in the months and weeks ahead. Fluoroscopy. So there's been some editorial revisions to some of the codes. In the past, it said physician only. So it required 1 hour of physician time in order to bill fluoroscopy. Now it says physician or other qualified healthcare professional. So they've broadened the scope of who can utilize this code set and report it. So rather than limiting the availability of this code by definition to a physician alone, they've stated that another qualified healthcare professional, we can report this time, but other qualified healthcare professional is going to be determined at a state and a credentialing level within each individual organization. So it has to be somebody whose time is billable. We generally think of non-physician practitioners, our nurse practitioners, our PAs. They can be credentialed directly with Medicare. So when we talk about qualified healthcare professional time, those are the kind of things that we look for. We'll look for information from some of our Medicare carriers about who they believe is qualified or who meets the definition of qualified healthcare professional. Our 3D rendering codes, there was some editorial revisions to this code as well, not in meaning though. And so historically, in the previous years, the code definition was just the 3D rendering and interpretation and reporting, and it would go on, and it didn't include the phrase other concurrent supervision. That phrase was a note underneath the CPT codes, underneath both 3D rendering codes. It wasn't included in the code definition. It was an annotation beneath the code. Now they've moved that into the code definition. It doesn't change the requirements though. So from AMA's perspective, these codes always required concurrent supervision. Now, concurrent supervision, we can't confuse that with our supervision of diagnostic tests, because that's a different level of supervision. That's defined by Medicare. It's defined, personal, direct, and general. Concurrent supervision is different. It doesn't have anything to do with the location of the physician, but it's the participation in the creation of 3D images. So their expectation for concurrent supervision is that the radiologist is actively participating in the process, that they're monitoring the reconstruction process, whether that's from their PACS workstation or over the shoulder of the tech. They're the ones that set out what needs to be, what images, what protocol, what center, what is going to be used to create the 3D images, and then monitoring those, adjusting those as they go, kind of tweaking them to be the final end product that the physician then uses with the interpretation. The other important thing is that with 3D, we always have to say to the PACS system at least the key images. We can't have just the original data set and say we can recreate the 3D if we need to. If we're going to build for 3D, we have to meet the definition of the code set, but we also need to save the key images of the 3D rendering that was done. Our CAD code. I don't really understand this update or why this update was done, but they removed the reference to physician review, and they've just changed it to with further review for interpretation. To me, that doesn't really change the definition of the code. It's computer-aided detection. The radiologist is going to review what the software identifies on that film as areas of interest and include that in the dictation. But they did edit, from physician, instead of saying physician review, with just further review. That's just a note. Joint stress application. This is another code that they changed from physician, or they added to physician the ability for other qualified healthcare professionals to be able to apply stress to the joint. So as you can see, other qualified healthcare professional might have to be an individual that can also bill this service, like the nurse practitioner or the PA. Joint stress application, that might not need to be a PA or an NP. That might be able to be a tech that can apply stress to the joint during the imaging process. So this qualified healthcare professional is a definition that's going to have to be hammered out between the organizations and the credentialing bodies as to what their interpretation of qualified healthcare professional is when it comes to these codes. Ultrasound of infant hips. Again, they've added this to be performed by a physician or other qualified healthcare professional that's performing the manipulation. So the same as the joint stress application, ultrasound of infant hips. It's just another area that you'll need to work on within your organization to define the qualified healthcare professional. Nuclear thyroid studies. There's some really good changes, I think, in our nuclear medicine section. The 7 existing thyroid studies were deleted, and now we have 3 new codes. I think they're much more clear, so instead of having 7 different pieces of a thyroid study, it's now a very straightforward coding scenario. So you can see they deleted our thyroid uptake, single, multiple, stimulation, imaging with uptake, imaging only, imaging with vascular flow. So all of these codes are now gone, and we have these 3 new codes. We have thyroid uptake, single or multiple, quantitative measurement. It includes stimulation, suppression, or discharge when performed. It doesn't have to be performed to meet the definition of this code. Then the next code is thyroid imaging, vascular flow when performed. So this is just flat thyroid imaging, but if vascular flow is performed, it is also included. Then our next code is thyroid imaging with single or multiple uptake, quantitative measurement. And then it includes stimulation, suppression, or discharge when performed. So they really simplified our choices for our thyroid studies, our nuclear medicine thyroid studies. Now our parathyroid studies, we have 2 new codes, and then they revised our existing code. And this was kind of challenging to represent more the type of parathyroid imaging being done. So now we have our parathyroid planar imaging. Then we have our parathyroid SPECT and planar. And then we have our parathyroid SPECT, planar, and concurrently acquired CT for anatomical localization. So when we think about our parathyroid imaging in the past, we would have, if we did a complete planar image and a study and a complete SPECT study, we would have 2 codes. Because they knew that was the way, that was now a standard protocol, we now have a code that is planar and SPECT imaging. And because frequently they do CT for anatomic localization, we now have that code as well. So these codes build on each other. If it's just planar imaging, you would do the 78070. If it's planar and SPECT, it's the 78071. If it's the planar, SPECT, and the anatomic localization CT, then that is 78072. And that should wrap up everything we do in a nuclear medicine parathyroid study into one of those 3 codes. Neurofunctional testing. This goes hand in hand with our neurofunctional MRI, or the functional MRI procedure. Previously, neurofunctional testing required a physician, and now performed by other healthcare professionals, so the psychologist can fit in the MRI and do the testing, the neurofunctional testing, and that would be represented by the 76020 code, rather than having to be the psychiatrist or radiologist sitting in there administering the test. So it makes more sense to have the psychologist be the one administering the questions during the functional brain mapping. They've updated the code so that that is reflective of what's happening. So now let's move into our interventional updates. For 2013, there's a dramatic change in net code. It's similar to the revision they did with our renal code, but it's, I think, far more reaching because these are much greater use codes. So all of our imaging codes have been deleted. There's no longer the arch angiography. There's no longer the external carotid, the internal carotid, the common carotid, the vertebral. All of those imaging codes are gone, and we now have one code that represents the imaging and catheter placement. And the impact, it goes beyond the head and neck, and we'll talk about some of the areas that are impacted by this change in codes as we go on. Our new comprehensive codes, they include vessel access, catheter placement, contrast injections, fluoro, all imaging, radiological supervision, interpretation, closure, and moderate sedation. So everything wrapped up into a neat little package with a bow tied around it. We can't assign 75774 for additional subselective imaging in the head any longer. So this code no longer can be used in the head and neck region. Now, these codes don't include the ultrasound guidance for vascular access. So if your documentation meets the standards for 76937, you can assign that. These codes also don't include 3D rendering. So if they're doing some 3D rendering to map, to plan for a stent placement or to plan for aneurysm repair, 3D rendering can be coded separately as well. So our first code, let's talk about our non-selective arch study. This code is, you place a catheter in the thoracic aorta, you inject some contrast, and you take the catheter out. That's it. The catheter isn't advanced beyond the aorta. This includes imaging of the branches or the origin of all the great vessels and the arch itself. So this is just our arch study, the 36221. So our example would be the physician punctures the femoral artery, advances the catheter into the aortic arch, injects contrast, imaging the arch and the origins of the great vessels so they innominate the less common and the less subclavian. So that's our arch study. Now we have our carotid arteriogram. And these codes are, we have to have a combination of catheter placement and imaging performed to get to the right code. So it's a little bit different than a code that just kind of, each code builds on each other. It doesn't really do that with each code. So 36222, you'll see a selective catheter placement in the common carotid or innominate artery. Unilateral, these are all unilateral by definition. And it's ipsilateral imaging. So it's ipsilateral extracranial imaging, and it includes the arch when performed. It's not required to image the arch, but if you do image the arch, that's not separately codable. So that's 36222. 36223 is selective catheter placement in the common or innominate with imaging of the intracranial and extracranial. So you'll see the catheter placement is the same as 36222, but in 36223, we're also imaging the intracranial circulation. So that would be one catheter placement and the imaging of the intracranial and extracranial arteries. Then 36224 is catheter placement in the internal carotid, and then imaging of the intracranial and extracranial. So that would be our next step up. So the first two codes have the same catheter placement but different imaging performed. 36223 and 36224 are different by catheter placement and similar with imaging. So let's break this down a little bit more. We can only assign one of the three codes per side. We always select the one based on the level of the selective catheterization and then the imaging performed. And then, again, these are not these are ipsilateral. So if you did a bilateral study, there would be one code per side. Our extracranial imaging outside the skull, we would have called it cervical carotid in our old code definitions. It's the mid and distal portions of the common carotid artery and the lower portion of the internal carotid. The intracranial is inside the skull, or what we would have called the cerebral carotid. So the rest of the internal carotid and its branches. So that would have been our internal carotid imaging study. And then, like I said, it includes imaging of the arch, whether it's done or not. So not doing imaging of the arch doesn't exclude you from using these codes, but it doesn't add anything to these codes either. So let's break it down and look at it a little bit different. Our highest catheter level, area image, and then codes. We kind of charted it out so that you can say, okay, where was my cath? I placed my catheter in my internal carotid, and I imaged the intracranial and extracranial carotid. That gets me 36224. If I just place my catheter in my common carotid, and I image the intracranial and extracranial, then that would be 36223. So again, it's two elements to look at to get to the right code to assign. So for example, a physician punctures the femoral artery and advances a catheter into the right common carotid and injects contrast for diagnostic imaging of the extracranial part of the carotid artery. That's 36222. Now, if the physician punctured the femoral and advanced the catheter into the left common carotid and injected contrast for imaging of the extracranial and intracranial, that would be 36223. And then if the physician punctured the femoral and advanced the catheter into the right common carotid and then performed an extracranial, and then he advanced the catheter further into the right internal carotid and performed the intracranial, that again, that's just 36224. So it doesn't matter that we stopped along the way. We stopped in the right common carotid and did our extracranial imaging, and then we advanced to the right internal carotid and did our intracranial imaging. That is still just our one code, 36224. So let's talk about our vertebral angiogram. Again, it's selective catheter placement. We have two codes. One is if the catheter is in the subclavian or the innominate artery, and the other is if the catheter is in the vertebral artery. So that's really the distinction between the two codes. When we're talking about catheter placement in the subclavian or the innominate, the imaging, to use these codes, the imaging has to be of the vertebral circulation. So we know that we might be placing the catheter into the subclavian to image the upper extremity. That's a different code set. So this will be placement in the subclavian to do a vertebral angiogram, so looking at the vertebral circulation. Again, if it's catheter placement in the subclavian or the innominate, that's 36225. If it's catheter placement in the vertebral artery, then it's 36226. And again, these are unilateral, so you would assign one for each side, right and left. And if the catheter placement was the same on both sides, so you went to the vertebral artery in the right and the vertebral artery in the left, we would be able to build them bilaterally. But if you went to the subclavian on one side and the vertebral on the other, we would bill the 36225 for the subclavian catheter and 36226 for the vertebral. So an example would be the physician punctures the femoral artery, advances the catheter into the right subclavian, injects contrast, and takes images of the right vertebral artery. That is 36225. If the physician punctures the femoral artery and advances the catheter into the left common carotid artery and performs the extracranial carotid arteriogram, and then he manipulates the catheter into the left subclavian and then further into the left vertebral where he injects contrast and does a vertebral angiogram, we have our vertebral code of 36226. And then we have our extracranial carotid with the catheter placement in the common carotid artery 362. So that would be those two codes. That's our vertebral and common carotid artery imaging. Now, our external carotid arteriogram. This is an add-on code. It can only be assigned with the codes for the 36222, 36223, or 36224. So the assumption is that the physician is going to first perform at least common carotid imaging before he moves into the vertebral to do the angiogram in the vertebral arteries. And the other piece of news with this is that this includes catheterization and imaging of all external carotid branches. So this is an area where we used to have multiple additional subselective catheter placements and subselective imaging. We don't have that anymore. 36227 includes imaging of all of the external carotid branches, so catheterization and imaging of all of the branches off the external carotid artery. That's a big change for radiology. In this example, we'll say the physician punctures the femoral artery, advances the catheter into the left common carotid, performs an extracranial carotid arteriogram. He then manipulates the catheter into the left internal carotid, performs an intracranial carotid arteriogram, and then he manipulates the catheter into the left external carotid and performs an arteriogram in that vessel. So we have 36224 because we did imaging in the left internal carotid, which is our more selective location, plus we did the intracranial and extracranial imaging. And then we have our 36227, our add-on code for the external carotid artery. Now, the external carotid artery, again, it requires the catheter to be placed in the external carotid artery and imaging performed. But that's not new. So the codes that we had last year required, in order to code for external carotid angiograms, the catheter had to be in the external carotid. So that's not new. What is new is that that is now the whole thing. It doesn't matter how many branches the physician navigates to outside or beyond the external carotid artery. That's all wrapped up into that one code. So we do have one other add-on code, the intracranial branch arteriogram. This is assigned only for branches off the internal carotid or the vertebral. It can only be assigned with 36224 or 36226. So they're saying to use this, our catheter has to be in the vertebral or it has to be in the internal carotid, and then we're moving to a vessel beyond those, one of those branch vessels. We can only use it twice per side. So if the physician catheterized one branch off of the vertebral artery and one branch off the internal carotid, both on the right side, that's it. You would only report it twice. So it's not twice per internal and twice per vertebral artery. It is twice per side. And beyond that, there's no additional codes. So it includes any and all branches beyond 2. So this example, the physician punctures the femoral artery and advances a catheter into the left internal carotid artery and performs an intracranial carotid arteriogram. He then advances the catheter into the left middle cerebral artery and performs an additional arteriogram in that vessel. We have 36224 for the imaging from the left internal carotid, and then we have 36228 for the branch off of the internal carotid artery. So one thing that all these codes are unilateral by definition. They all say either unilateral or ipsilateral imaging. It's important to follow your payer guidelines for reporting bilateral studies. And if the exact same service is not performed on each side, then you wouldn't use the bilateral code. You would use the code that represents the service performed and use the 59 modifier. So for example, you had your catheter placement in the internal carotid on the right and in the common carotid on the left. That gives you 2 different levels, and so you would report the internal carotid as your first code and then the common carotid code with the 59 modifier. So in this example, we have the physician punctures the femoral artery, advances the catheter in the right common carotid, performs an extracranial and intracranial carotid angiogram, catheterizes the left common carotid and performs an extracranial carotid angiogram. He then catheterizes the left internal carotid and performs the intracranial carotid angiogram. So we have 36224 for the left because he went into the left internal carotid. He actually placed this catheter there. That's the most selective catheter placement location. On the right side, the catheter placement was only in the common carotid for both the intracranial and extracranial imaging. So that's our 36223 with the 59 modifier. Here's an example of a bilateral code. So we would say the physician performs a 4-vessel arteriogram. He catheterizes the right and left internal carotid arteries, performing intracranial imaging on both sides. He also catheterizes the right and left vertebral arteries and performs the vertebral arteriogram. So we have the 36224 for our right and left internal carotid arteries, and then we have 36226 for our right and left vertebral arteries. I think it's important to note that right now, CMS has set these codes up incorrectly, the 36222 through 36226. They've set them up to not be bilateral studies, which means that right and left and 50 you'll receive denial. And many people started receiving denials after the first of the year. Recently, there was a communication from the ACR that CMS has recognized that mistake and they'll work on fixing that. We don't have a deadline for that, so we're not sure what the date of that correction will be. But that is something to look for in the coming weeks. That hopefully CMS will fix that and we'll be able to file these with our 50 modifiers rather than having to report them on 2 lines with the 69. So we still have our catheterization codes. Those have not been deleted. So we have our introduction of catheter into the aorta. This is only if, the catheter is placed only in the aorta and we don't go anywhere else. We don't use these catheter codes anymore if any diagnostic imaging is performed. So if we're doing diagnostic imaging in the head and neck and we place the catheter in the aorta, we don't use this. We use our ARCH, cath, and imaging codes combined. We still have our first, second, third, and each additional order catheterization codes. Again, we don't use these if we perform diagnostic angiography. We do use them. They had to leave them out there because there's some procedures where the catheterization isn't included in the interventional procedure, but all the imaging necessary is. Or the catheterization isn't included in the procedure, and we don't meet the definition of being able to bill a diagnostic angiogram because either they had one or we don't meet those separate and distinct guidelines as published in the CPT book. So in those instances where we don't do an angiography or we cannot code an angiography, we still use these catheterization codes, and the definition and the use of them hasn't changed. So some of the issues that are going to come up this year until we receive some further clarification are if we do an ARCH study with an upper extremity angiogram. So if the physician does the ARCH study and then he catheterizes the subclavian vessel and does imaging of the upper extremity, not of the vertebral arch circulation, but of the upper extremity, we have the only code we have now for an ARCH angiogram is the 36221, which by definition includes catheter placement and imaging. Then we still need to have our catheter placement into the subclavian and our unilateral angiography. So from a coding standpoint, to represent all that we did, we're kind of stuck now. We have our ARCH aortogram code. We have our catheter placement code. If it's the right side, it's 36216. If it's the left side, it's 36215. And then we have our unilateral angiography of the extremities. We don't, at this point, have any guidance in the ACR on this type of scenario. We're looking for that to come out in the future, to give us some additional guidance on the expectation for reporting these. At this time, this is our only solution. So an example would be the physician advances the catheter into the aortic arch and performs an arch angiogram. The physician then advances the catheter into the left subclavian artery and performs a left subclavian arteriogram with imaging over the upper extremity. So on the left, we have our catheter placement in the subclavian artery, which is 36215. We have our ARCH angiogram, which is 36221, and then we have our upper extremity imaging, which is 75710. And at this time, there are no CCI edits for this code combination, so there wouldn't be a need to use the 59 modifier. So let's talk about neuroembolization. 61624 does not include catheterization. We would use codes 36222 through 36228 only if we meet the CPT criteria for performing the diagnostic angiograms prior to the procedure. So if we don't meet that definition of a diagnostic angiogram, we would use our standard catheterization codes. If we do meet the definition to have a diagnostic angiogram on the same day as a therapeutic procedure, then we would use the new codes of 36222 through 36228, depending on the catheterization and the imaging performed. So that's one area. That's another area that this change in code set impacts when we're talking about the head and neck imaging. So if a physician catheterizes the right internal carotid, performs a cerebral arteriogram, which reveals an aneurysm of the distal internal carotid, the physician then catheterizes the aneurysm and deploys coils A follow-up angiogram is performed in the right internal carotid to evaluate the results. Okay, so first of all, we know based on this snippet of information that the physician performed an angiogram that revealed an aneurysm in the location of that aneurysm. We did not know prior to this point that the patient had an aneurysm. So that gets our separate and distinct diagnostic study. And based on the results of that diagnostic study, we're proceeding with our interventional procedure. So our diagnostic study, the 36224. Now we're going to go ahead with our coils, placing our coils in the aneurysm, 61624, the image guidance for that, 75894. And then we have our follow-up angiogram, 75898. We have another example of when our diagnostic angiogram does not meet the definition. In this example, the patient had a prior catheter arteriogram and returned for treatment of a known aneurysm of the distal right internal carotid. So they had a prior catheter-based angiogram, and we know where the aneurysm is. By femoral access, the physician catheterizes the right internal carotid, performs a cerebral arteriogram, and confirms the presence. So again, he's not diagnosing it. He knew it was there, and he's just confirming that it's where he thought it was. And then the physician catheterizes the aneurysm, deploys coils, and performs a follow-up angiogram. So in this instance, we only have our catheterization code, the 36217, and then we have our embolization, our 61624, 75894, and then 75898 for the follow-up angiogram. Okay, so temporary balloon occlusion. 61623 is a comprehensive code that includes catheterization. Our instructions were that appropriate RS&I codes should be assigned if the physician performs a complete diagnostic arteriogram of the vessel that's to be occluded. So with our code change, we can't report just the RS&I codes. We have no good solution for this scenario now. So our temporary balloon occlusion 6163 includes catheterization but not diagnostic imaging. And so we will be looking, there's no scenario in the 2013 CPT manual or guidelines from the AMA or the ACR at this point for how to handle this. So we'll be watching for guidance on how they expect us to report these types of codes when we have diagnostic imaging in addition to the temporary balloon occlusion. For extracranial procedures, so if we're talking about all procedures performed in the extracranial head and neck, we have the new external carotid comprehensive code that includes imaging of all branches. So that's our add-on code. It's imaging of the extracranial or the external carotid artery and all branches backed up into that one code. So this, our 6166, is our extracranial embolization in the head and neck vessels. So it's for all procedures performed in the head and neck. So an example of this with our new codes, if we have a patient with an intractable left-sided epistaxis and they present for angiography with possible embolization, so we don't know if we're doing embolization yet. That kind of sets the stage for us. The physician, by femoral access, advances the catheter into the left common carotid artery and performs an extracranial carotid arteriogram. He then advances the catheter into the external carotid, and it performs another angiogram. And then he advances the catheter into the IMA and performs an additional angiogram. The physician then embolizes two branches of the IMA, and follow-up angiography is performed. So in this instance, we have 36222 because we had the catheter into the left common carotid, and we did our extracranial imaging. That's 36222. Then we have our external carotid in imaging and catheter placement, 36227. And then we have our embolization, the 61626 and the 75894. And then we have our follow-up angiography, which is 75898. So we don't get any additional catheter placements or imaging to the IMA or branches of the IMA. All of that is included in our 36227. Thrombolytic infusion. Okay, so they totally redid the infusion, the thrombolysis code. We have 4 new codes now. This is another big change because they've talked about some restrictions with using these codes. So our transcatheter therapy, we have arterial infusion, initial treatment day, and we have venous infusion, initial treatment day. So they've redefined the code by day of service. And then it is arterial or venous on the initial day. And it includes everything. Our next codes are subsequent day and then final day or cessation. So our subsequent day includes any imaging. It includes continued. It includes follow-up contrast injection through the catheter. It includes removal or repositioning exchange of the catheter. All of that is in subsequent treatment day. So no longer do we have our follow-up angiography through existing catheters when we're doing thrombolysis. When we do cessation, it includes everything plus the removal of the catheter and vessel closure. Let's look at this another way. One code per day of treatment. So if it's the initial day, it's everything that happens on that initial day, including if you start thrombolysis in the morning and you finish it at 11:30 at night, that is initial day. That is the one service. There's nothing else beyond that one code. So initial day, subsequent day, final day. We can break it out and look at it like this. Our initial days include the initiation of the infusion, the radiological supervision, interpretation, fluoroscopic guidance, follow-up angiograms, catheter repositioning, catheter exchange, discontinuation of treatment on the same day of initiation. All of that is our initial treatment day code. Continuation of infusion, RSNI, fluoroscopic guidance, catheter repositioning, or catheter exchange, all of that is included in our subsequent day. And then our final day is follow-up angiograms, discontinuation of infusion, removal of catheter and vessel closure. All of that is our final day. So when we talk about thrombolysis codes, it's also important to know that it includes moderate sedation. So we can't bill moderate sedation separately with our thrombolysis procedures. They don't include catheter placement. So catheter placement would be coded along with the initial thrombolysis procedure code, not with the subsequent one. They don't include the initial diagnostic angiogram as long as it meets our CPT criteria. They don't include other percutaneous interventions unrelated to the thrombolysis. It also doesn't include vascular access. Now, they say they don't include unrelated E&M services on the same day of the treatment, but that's really kind of outside the standard process for radiology. If the radiologist is seeing them on the same day as thrombolysis, it's probably related to the thrombolysis. If there was something else going on that they were seeing the patient for, then that unrelated E&M service, as long as it meets that definition, could be assigned as well. So clinical examples in radiology have said delivering hand injections or very short pulse spraying does not qualify as transcatheter infusion. So it doesn't matter if the physician comes in and does some pulse sprays and leaves and comes back in a few hours and does some more. Delivering of hand injections or short pulse sprays is not transcatheter infusion. Dr. Roddy at the CPT Symposium says that these new codes require the use of an infusion pump. So, you know, they've really narrowed what their definition of thrombolysis is. You hook the patient up to a pump, they leave the IR suite or the angiography suite. They go to their room someplace else, and the infusion continues. And then these can be reported more than once if the patient's having bilateral infusions. The important thing is it's separate accesses. So if they have an access placed in the left common femoral artery and the right common femoral artery, and they're running two catheters up, even if they're both directed at the same spot, it's two separate accesses, two separate infusions, then we can report a right and a left. So this is an example. A patient presents with acute right leg pain. The physician punctures the left common femoral artery and advances the catheter into the distal abdominal aorta, performs a bilateral lower extremity arteriogram that reveals a clot in the distal right popliteal artery. So the physician positions an infusion catheter in the right popliteal and begins TPA infusion. So we have our 36247 for our catheter placement, our 75716, because we did a bilateral lower extremity angiography that meets the definition, and then 37211 for our initial day. This is an example of our subsequent day. A patient with a right subclavian vein thrombosis is receiving TPA via catheter inserted in the right basilic vein. On day 2, the physician performs a follow-up venogram which reveals partial dissolution of the clot. The physician then advances the catheter and then continues the infusion. All of that is reported with 37213 because, again, it includes adjustment, removal, replacement of the catheter, as well as all imaging. Now, this is an example of a cessation or our final day of treatment. The patient with right subclavian vein thrombosis is receiving TPA. On day 3, the physician injects contrast through the catheter, which shows complete resolution of the clot. Therefore, the infusion is discontinued and removes the catheter. 37214 would be the code to assign for this. So let's talk about cerebral infusion, thrombolysis by intravenous infusion. This is something only hospitals will be paid for. Physicians aren't reimbursed for this in the hospital setting. I believe they're thinking that, patient is hooked up to an IV and medication is running through the IV. That's not really a physician service. So only in the hospital setting, only the facility will be paid for the IV infusion. Non-thrombolytic infusion, transcatheter therapy other than thrombolysis, so spasmolytic drugs, that's not, so the injection of a spasmolytic drug is not infusion. This code was originally created for infusions that took an average of 30 minutes. There's not a time definition in this code, so it's really important to know what your payers expect from a documentation or a procedure standpoint when you're reporting the non-thrombolytic infusion. Some payers have a definition of, infusion is 16 minutes. If there's a time definition for your payers, the physicians need to document the length of time that the infusion, the start and the stop time, so they don't have to say it lasted for 15 minutes. There should be documentation that the infusion started at such time and the infusion, was stopped at and give that time, and then that way we have the length of time that the infusion took place. Transcatheter therapy infusion for other than thrombolysis, that is new. They've entered the description of this code because of the redefining of the thrombolysis code. So now our transcatheter therapy image guidance code now says other than thrombolysis. It includes diagnostic angiography. Well, it doesn't include diagnostic angiography procedures that are appropriately documented and are truly diagnostic in nature. They're separately coded. And this is once per operative field. Our angiography through existing catheter for follow-up study, you'll notice this now says other than for thrombolysis, so they've changed that definition to exclude it for being used for follow-up angiography through the thrombolysis catheter. It's, again, once per encounter per operative site. Hospitals, it's conditionally packaged, but that doesn't mean you don't report it. Because it is a cost associated with performing procedures, it should be reported with the primary procedure whenever it's done. Foreign body retrieval, that's another new code for this year. We have our comprehensive code that includes all image guidance for the procedure. It's transcatheter retrieval percutaneous of intravascular foreign body. And we used foreign body retrieval most frequently before we got specific catheter codes or specific filter codes. Now that we have our filter codes, the foreign body retrieval code we would use most frequently for fractured catheters, retrieval of a broken piece of a catheter that is retained by the patient. An example would be a patient sent to the interventionalist for removal of a retained fragment of a central venous catheter that was seen on the chest X-ray. The physician punctures the femoral vein and advances the catheter into the right atrium, injects contrast for a pulmonary angiography. This reveals the fragment to be located in the right pulmonary artery. The physician inserts a snare into the right pulmonary artery, removes the fragment, and performs a completion angiogram and shows there's no other foreign bodies. So we meet the definition of a diagnostic study on the same day as an interventional therapeutic procedure because coming in, we see the patient, this was seen on a chest X-ray. It wasn't seen on a prior catheter-based study. So other imaging outside of catheter-based studies don't prohibit us from doing the diagnostic angiogram. So it's, one of the criteria is if there's no prior catheter-based study. So we meet that. And then his decision to perform intervention is based on what he saw in that diagnostic study. So we have our catheterization of the pulmonary artery, that's 36014. We have our imaging of the pulmonary artery, 75746 with a 59, because our foreign body removal code includes all imaging necessary to complete that procedure. So we have to have our modified 59 on the pulmonary angiogram, and then our 37197 for our foreign body removal. Thoracentesis, another set of changes for us this year. Generally, the aspiration of fluid from the pleural cavity is performed for pleural effusion, and it can be diagnostic or therapeutic. It can be taking a sample to send to the lab for analysis, or they can just be removing pressure from the chest. We have new codes, so 32554 and 32555. In radiology, we should just be using 32555. We generally don't perform procedures without image guidance, so we would always use the image guidance code. The change with this code is now the code says needle or catheter aspiration from pleural space. So it doesn't matter if it's a needle, it doesn't matter if it's a needle followed by the catheter, or it doesn't matter if it's catheter. So however the fluid is removed, we use that code. And then we don't have any separate codes for image guidance, so we don't use our modality-specific codes anymore. It's all included in the 32555. Now, the code's also unilateral, so if you have to do the aspiration of thoracentesis bilaterally, you would follow your bilateral billing guidelines. And then we can't do this code in addition to a tunnel pleural catheter or the open chest tube placement. So this would be just the aspiration, no additional catheter placement, no drainage. So our chest tube placements, our drainage procedures are two new codes as well, 32556 and 32557. 32557 is the code we should be using in radiology. Again, it's regardless of how the fluid is removed. The important thing is that it's drainage, so the patient leaves radiology with a catheter in place, with that drainage tube connected to a bag, vacuum, something. But the catheter is still in that patient when they leave radiology. And then it does include image guidance, so we don't use our modality-specific image guidance with these codes. And it's unilateral, so if you place bilateral chest tube, you would report this following your bilateral billing guidelines. There is no code for the removal of a non-tunneled chest tube, and we can't report, chest tube placements with insertion of tunneled pleural catheters or open chest tubes. So it's really important that we keep those separate. The other kind of glaring thing that we really need to think about, especially when we use CDM so much, is that the existing chest tube code has not been deleted. They modified the description. So we cannot use 32551. It is an open surgical procedure. In our systems these days, because we generally have procedures carry over from one year to the next, we still need things to get paid and reimbursed, claims filed. We can't delete codes, but we need to have something in place to make sure that we're not using 551 inadvertently, because it is an open surgical procedure. We have to use one of the new codes. I've seen on some of the listservs that people are getting denials for 32551 because it was in their CDM, it was part of the CDM, and because it's still a valid code, they're getting denials saying that this is not reported in the correct or in an appropriate setting. So it should have been a hospital setting rather than a physician office setting or whatever the setting difference was. So that's a very important thing to keep your eye on. Moderate sedation codes. Some of the codes they've been revised to include that whole definition of other qualified healthcare professionals, just like several of the other codes. There's been codes added to the list of codes that include moderate sedation. So introduction of a catheter into the inferior vena cava or the superior vena cava, that code now includes moderate sedation. Introduction into an extremity artery, 3614, that now includes moderate sedation. If you're doing vertebroplasties, that includes moderate sedation. So each year it's important to check that list of codes that moderate sedation is included in, because they will add codes to that. So now let's talk about some of the wrap-up stuff. PQRS. It's really important that we begin or continue the conversation with a radiologist about PQRS. Hopefully it's not beginning. Hopefully everybody has started that conversation and is reporting some of the codes. based on some studies by the ACR, though, it's not, radiologists aren't participating at a level they should. So until the year 2015, it's voluntary. For 2013 and 2014, physicians will still receive an incentive payment if they meet the reporting criteria. Beginning in 2015, physicians will start receiving a reduction of 1.5% and then 2% years after that. The important thing to note is that they're going to calculate the participation for 2015 on 2013. So if you're not participating in 2013, you're going to have a reduction in 2015, unless they change something in their final rule. But right now, as they have it written, they're going to look at the participation and the reporting done in 2013, and that's what they'll base the reductions for 2015 on. So it's very important that we have our radiologists involved in this process, and we find a way to report effectively the PQRS measures that apply to our group. Currently, the ACR says about 20% of the radiologists participate in PQRS, and much of that is because the cost to participate is much more than any benefits that they may receive from that. At some point, though, it's not just the cost of participating; it's going to become the penalty for not participating. So it will cost less, and you'll receive less reimbursement. So it's really important that they understand this, and that we get submitting that information in 2013. There's a lot of different ways that you can submit PQRS measures, and I won't go into detail on any of them, but because there's a lot of other places you can get information, but you can submit them through claims, through registries. There's some EHRs that have been qualified so that they can submit directly from the EHR. There's some administrative claims reporting mechanisms for really large groups. So it's important to investigate that, talk with your vendors, find a way to report that information that makes sense. There's also some information on the ACR website. They have a PQRI wizard. They can help decide how you're going to report it. They can, there's a lot of things a lot of information that they have available. They've kind of identified some of the PQRS measures that they believe apply to radiology, so you don't have to filter through all of them. They'll have the interventional and the diagnostic radiology PQRS measures that they believe, radiologists should be able to report under. So looking at those, that's a good start to finding out and developing your reporting process. All right, that is the end of the presentation. I believe we're ready for questions, Trish.
Okay, great. And just a reminder to everybody on the line, if you do have questions, to just use the dashboard that's on your screen. I'm going to answer a few general questions that are not related to the presentation that have been coming in, so everybody's on the same page in terms of awareness. We will be distributing the PowerPoint slides later this afternoon. We are not cruel people who expect you to remember every single one of that pieces of information, so we will be providing that to you later this afternoon, along with an audio playback option, so you can watch this at a later date when the time is convenient for you. With regard to CEU, there is not, unfortunately, any CEUs available for this particular webinar. And we did have another question come in about how to be notified for future webinars that Orion is providing, and we are happy to add you to our distribution list if you could just send us your email address, or we could just add the email address that we have on file for this particular webinar to our list. So if you are interested in that, please feel free to reach out to me, and you should all have my email address. And if you don't have it currently, you will be getting an email from me later this afternoon, so you could just reply to that. With regard to specific content questions, we did not actually have anything come in. So Jenny, I think that you covered everything, and we will provide again the audio and slides later this afternoon so people can listen to that at a later date. So we do appreciate your time, Jenny, and thank you everybody for being on the line with us. And if you have any content questions that you did not pop into us and you do want to contact us after that, you'll be receiving both of our contact information later this afternoon. So we appreciate your time, and we will see you next month.